Thank you very much. I'd like to discuss the problem or the situation of normal report in a patient who's not really feeling well. I think everybody who's a neurosurgeon has seen the patients come with now a box of discs, in the past a paper bag full of films that were all read as normal, and the patient doesn't feel well, and the study's really not so normal. The discordant imaging report, it's really the problem of a patient with trouble and a report read as normal. And this can be related to incorrect interpretation, the incorrect examination being performed, or a non-diagnostic study being performed. There's a recognized phenomenon, spinal cord injury without radiographic abnormality. It's simply that it's a recognized problem that the patients are going to be worse than their imaging. This is typically a function of the examination not appropriate for making a diagnosis of soft tissue injuries or the problems with spinal cord injuries. Typically, CT evaluates bones and some of the soft tissue well. MRI will look at cerebral spinal fluid spaces, bones, and neural tissue. We don't evaluate ligaments well. We don't evaluate muscle well. Excuse me. The misinterpretation is by and large due to lack of awareness both on the part of the radiologists and the end of multiple medical specialties. I'm in community practice, so typically I'm seeing people who've been referred with other issues, other problems in a referral practice. There's less of an issue, I think, following a diagnosis of Syring's Chiari malformation and hypermobility. Typically, subtle findings are unnoticed and major findings may be misunderstood. In the face of ignorance, it's also very tempting to simply follow a previous negative report as negative. It also tends to stick with patients on their histories and charts and their medical records. Examples of things that we've noticed not interpreted correctly include basilar invagination, Chiari malformation, impingement at cervical medullary junction, mobility with both antero and retrolisthesis, abnormal position of conus, fatty infiltration or thickening of filum terminale, and the confusion of tethered cord as a radiologic diagnosis. Too many cases have come through and been read as no tethered cord, but tethered cord isn't a radiologic diagnosis. It's a clinical diagnosis. This is a case of basilar invagination. The odontoid projects through foramen magnum with impingement. This is it turns out, a 70-year-old who fell, was dizzy and lightheaded, and the study was interpreted as normal. I was called up and said, "This guy looks really bad. What's going on?" This is a very nice young lady who's a radiology technologist in Texas and has had headaches, weakness, and a series of studies that were interpreted as normal. This is a preoperative examination, but the clival axial angle was 130 degrees and a Grab-Oaks measurement was performed, and she had almost 9 millimeters. And this study had been read as normal several times. This is another case that was misinterpreted, and there's posterior inclination of the odontoid, there's abnormal clival axial angle, there's abnormal Grab-Oaks measurement, and there's Chiari malformation, and this came across as a normal examination. There's the issue of antero and retrolisthesis. It's tempting, well, that doesn't. It's tempting in a neutral position. One of the problems of mobility or instability is that it's dynamic, and typically we're looking at one position, a neutral position. When people give hyperextension, there's a lot of mobility here, and there's anterolisthesis at C1, C2, C3, C2, C3, C3, C4, C4, C5. It's worst at C4, C5. This is a essentially negative study, but it's got to be considered that there may be other issues going on. A 24-year-old with long-standing headaches had a fall, worsening of the headache, and bilateral upper extremity weakness. Both the CT and the MRI were interpreted as unremarkable, but someone thought it through and said, perhaps we should look at the lumbar spine. and there's fat in the phylum terminale, though the conus ends at the L1 level. Anybody who's coming through with symptoms and a lipoma or fatty changes of the phylum terminale we consider to have a tethered cord. This is another person with a much, much more subtle finding of fat in the phylum. We expect tethered cord is going to be occult, and the imaging should have normal appearance with normal location of the conus, no real skeletal abnormalities, and no thickening or fatty changes of phylum. Typically, we expect to do imaging to look for other problems such as spinal stenosis or a disc herniation. And just that this is a conus at position of upper L3. The range of normal is considered from lower T12 to the L2-3 end plate, upper L3. It's going to be questionable. Unfortunately, this person was symptomatic, lower extremity weakness, pain way out of proportion to her degenerative changes, and there's fatty changes of her lipoma, fatty changes with a small lipoma. And the other issue was the correct study performed. For segmental instability, flexion, extension, imaging is critical, and for instability at C1, C2, it's largely rotation at the joint, and rotational images are needed. So this is a 40-year-old who had a series of exams which were read as normal, but she had debilitating weakness, leg weakness, and fatigue. And in hyperextension, she's got a disc protruding at C5, C6. In extension, she has almost 30 degrees motion. And the other problem is non-diagnostic imaging. In a neutral position, there's minimal degenerative changes and motion at the C5, C6 level, whereas the flexion doesn't demonstrate it. So this was a non-diagnostic study. The issue of rotation, there was recognized impingement at cervical medullary junction. This is flexion CT, this is extension, but there's nothing here that's going to evaluate the C1, C2, and a rotatory study showed that she could turn 85 degrees at C1 and 40 degrees at C2, and 45 degrees is a lot of rotations. Punjabi and White suggest 37 degrees is the upper range of normal. And I consider anything above 41 probably abnormal, significantly abnormal. I don't know that it's directly going to be twisting nerves or pulling on blood vessels, but it's a correlate of ligamentous instability to have this degree of rotation. And I'd like to thank you for your time and energies.